In the name of the project team, constituted by Sarah, Pete, Hector and me, I'm going to talk about a project aiming to investigate the views of EQuiP delegates on the subject of equity in primary care. This project was born in a context where social inequalities in health have been described in many European countries. The context is also that in every country seeks to improve the quality and performance of their health care system. So the question are, and you will recognize Hector's motto, is primary care part of the problem or part of the solution? And is equity a potential area for the improvement of the quality of primary care in Europe? The two aims of the project are: how do EQuiP delegates relate to the concept of inequity or equity in healthcare, and to what extent are the European primary healthcare systems perceived as equitable in their delivery of care? The method of the project is quite simple. Everything began in last November with a meeting in Paris, gathering researchers and health professionals, some of them being hybrids of the two species. And the redaction of the first questionnaire was made by the team of the project, and this first questionnaire was revised by experts and the project team, and they were experts in the field of equity in healthcare. We were proud to have the contribution of John Furler from the University of Melbourne in Australia, Yann de Masner, who is Sarah's boss, from the University of Ghent in Belgium, Florence Juzo from IRDES, France, Christos Lionis from Greece, Maria Godard from the University of York in UK, and Kevin Fisela from the University of Rochester in USA. The opinion of EQuiP delegates was collected via an online survey that was sent to 41 delegates from 24 European countries. There were 1, 2, 3 delegates per country, and all of them were asked to answer as their role as representative of their country. The 15 questions were organized in 4 themes, exploring first the place of equity in the organization of healthcare and in day-to-day practice in primary healthcare. 2, equity in relation to quality of care. 3, improving equity in healthcare. And finally, EQuiP and equity in primary healthcare. A quantitative and qualitative analysis is in progress. So, today we are able to show you the first results, and I'm sorry, but dear EQuiP delegates, be prepared to be asked for some precisions. We were very happy to have a very high participation among EQuiP delegates. We obtained responses from 24 of the 24 countries, and 35 of the 41 delegates took a lot of time to answer to the survey. All the countries are listed here. The results will help us to answer 2 simple questions. Is equity a problem? Is there any room for improvement? And in the third part, we will wonder if equity can be a topic for EQuiP. So, is equity a problem? It seems to be. It appears that equity is an important issue for many European health systems. For example, national organizations show their will to achieve equity in health. In UK, for example, a brand new Marmot review was issued in March 2013 called Working for Health Equity, the Role of Health Professionals. The Irish Medical Organization produced in 2012 a position paper on health inequities. In Portugal, there is the Plano Nacional de Saúde, 2012 a 2016. And in France, in 2012, there is a rapport annuel du Haut Conseil pour l'avenir de l'assurance maladie. Some colleges of GPs also issued position papers. Of course, the Royal College of General Practitioners, The paper is called Addressing Health Inequalities, a Guide for GPs, and it was issued in 2008. The Irish College of General Practitioners issued the position paper on health inequity in March 2012, and there is also the German College of General Practice in 2012 also. Equity is finally an important research project, of course at the University of Ghent in Belgium, at the University of Creta in Greece, the University of Copenhagen in Denmark, and for INSERM in France. So, we asked EQuiP delegates if equity was taken into consideration in the assessments, one, of the quality of the primary health care system in their country. The answers are represented in orange. And two, if equity was taken into consideration in the assessment of the quality of care at the practice level. And the answers are represented in white. Histograms represent the number of delegates who gave each proposed answer, and in each histogram you can see, well, I'm sure you can't see, but you have to guess, you can see the name of the countries. As you can see, equity is very rarely taken into consideration to assess equity. At both levels, in fact, equity plays an important role in the assessment of quality in only 3 countries, which are Austria, Netherlands, and United Kingdom. There are also many countries in which the question is not applicable since quality itself is not assessed. And it is all the more difficult to assess equity as the social data of the patients are rarely recorded. We asked EQuiP delegates if the socio-economic status of their patients were systematically recorded, and as we may guess, the answer is no for 26 delegates. Recording the social status is even forbidden by the law in Finland, if I understood well. And the item which is most often recorded is the patient's health insurance status. Although not recorded, inequity is often encountered by European GPs. Daily organizational and structural barriers to practice in an equitable way are very common in the practice of primary healthcare in European countries. 17 delegates said that the primary care workers in their country were confronted to those barriers. And as you can see, in some countries, delegates disagreed on this point, which may illustrate the need for a common definition of equity among EQuiP delegates. According to the delegates' comments, we identified 4 types of barriers to equity in primary care. The financial barriers, the lack of resources, the problem of waiting lists to secondary cares, and communication barriers. For each category, I will quote only 1 or 2 of the many comments of the delegates, and choosing has been really frustrating, as a lot of very interesting comments were made. First of all, there are financial barriers to access primary care, of course. In Estonia, for example, health insurance does not cover all population. People without health insurance have to pay for their primary care services themselves, and usually those people are not able to pay and avoid primary care until their health problem has escalated to an emergency. In Germany, depending on the area where the practice is located, patients have problems to finance the co-payment, which is €5 for their medication. The fee-for-service system is, as a whole is also often denounced. The second barrier is, of course, the lack of time and the lack of money. In Croatia, a delegate said, we have too much consultation per day and it is very hard to talk about equity in this situation. In France, fee-for-service payment is a strong barrier. It does not take into account complicated encounters with patients with complex needs and social needs. I think that it's a barrier to take time when it's necessary. The third type of barriers are the waiting list to access to secondary care. In Norway, there are long waiting lists for specialized services, so rich people buy health insurance or buy their way into private health services. The same occurs in Ireland. In general practice, referral to specialist outpatient care depends on whether or not patients have private insurance, short waiting times and patient pays, or goes through the public system, long waiting times and taxpayer pays. The last barriers are communication barrier. An Austrian delegate said, I believe the most important source of inequity is the language and cultural barrier towards citizens with a foreign background. There is definitely room for improvement here. Is there a way to knock those 4 barriers over? So a majority of delegates sees opportunities for the improvement of equity in primary care. 26 delegates think that it is necessary, possible to improve equity in primary healthcare by actions at the level of the healthcare system, whereas 22 delegates find it possible to improve equity in primary healthcare by actions conducted directly at the practice level. 9 levels of action, both at the practice level and at the healthcare system level, were identified to improve equity. To answer the first barrier, a first opportunity of improvement would be to promote universal access to health insurance and to lower to a minimum the patient financial participation, the out of the pocket. A delegate from Portugal proposes to fight inequity by promoting universal coverage with no moderating taxes in primary care and increase the response on secondary care healthcare providers. In Germany, with the beginning of 2013, the fee for access to the practice, 10 euros, was skipped. This is an improvement regarding equity. Public health actions can also be a way to reduce inequity. In Italy, for example, we consider a national-wide screening campaign, HPV vaccination, HVV vaccination, colorectal cancer, breast cancer, etc., equitable quality in primary health care. To fight the second and the third barrier, it has been proposed to adapt primary care organization resources according to the health needs of the patient. In a Marmot review issued in February 2010 and called Fair Society, Healthy Lives, we find the idea of proportionate universalism. For EQuiP delegates from Belgium, we know who this is, more support for the practice by providing staff and time or money to take up responsibility for socio-economic frail people and group of patients. In France, the payment system can be changed taking into account the complexity of the person, education, social environment, multimorbidity resources. For example, different encounter lengths according to patient needs and payment of the doctor according to the length of the encounter. More than adapt the resources to the health needs, delegates propose to overcompensate areas of social deprivation. A delegate from Sweden said, I think it's necessary to economically overcompensate health centers in poor areas to make it possible to have more GPs per 1,000 inhabitants and to have counselors, social workers, etc. at the health centers. To be prepared to face and deal with inequity, health professionals should be educated and trained on equity both at under- and postgraduate level via continuing professional development. First of all, of course, an explanation of the term of equity in PHC is needed, and then assessment, which was quoted by somebody from Poland. And a delegate who have worked as a GP in both poor areas with many immigrants and in more affluent areas said that the key is that all those who work at the health center understand the differences in people's control over their lives and how powerlessness breaks down your sense of initiative. Beautiful phrase. answer. There are different ways to fight both language and cultural barriers. Our fourth barrier, for example, the use of interpreter, as a delegate from Austria said, patients with foreign background don't receive adequate care. We would need a translating service as well as facilitator, e.g. physician's assistant, practice nurse, to improve communication with these patients. Patient information material in different language could also be very useful. And we have the example in Emilia-Romagna in Italy, where the cultural mediator is active for refugee at the primary care level. It seems important, of course, to promote cooperation between primary care services and social workers on the one hand, and between primary and secondary care on the other hand, as underlined by a French delegate. We need time and better interprofessional cooperation to be successful, and cooperation between medical and social sectors. I think that only one delegate talked about empowerment, but I am sure that Hector would have talked about empowerment if only he had filled in the questionnaire. According to the World Health Organization, in its 2008 report called Primary Health Care, now more than ever, it says that empowerment strategies can improve health and social outcomes through several pathways. The condition for success is that they are embedded in local context and based on a strong and direct relationship between people and their health workers. One of the strategies is, for example, to increase citizens' awareness of their rights, needs, and potential problems, for example. At last, and as a transition, a way to improve equity is through continuous quality improvement to measure and monitor equity. Recording data about the patient's social position and patient outcomes could be a beginning to measure equity. Somebody said it from France, and somebody from Israel. By comparing different groups in the country according to quality indicators and outcomes, we can target specific needs. This is already being done in the case of diabetic care. Equity is an issue in primary healthcare in Europe, but fortunately we identified many ways of improvement. Our last question is, do you think equity could be a topic for EQuiP? As you all know, at the international level, equity is one of the 6 dimensions of the quality of healthcare. The 6 dimensions are safe. The healthcare has to be safe, effective, patient-centered, timely, efficient, and equitable. This is the last one, but it exists. And equitable means providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socio-economic status. In our survey, EQuiP delegates looked quite motivated by the topic of equity. They were asked to rate their agreements with 2 statements. In fact, from 1, I do not agree at all, to 5, I totally agree. The first statement was, equity has to be elevated to a measured domain of quality, in primary health care. The results are represented in orange. And we consider that 26, which is the sum of 4 and 5 of the 35 delegates, agree with this statement. The second statement was equity in PHC could become a topic for a new working group in EQuiP, and to a lower extent, delegates also agreed with this second agreement. As a conclusion, we will list potential aims for a new working group in EQuiP, define and clarify the concepts surrounding equity, write something, a position paper, statement, or a recommendation on equity, create and share a database of documents concerning equity from European countries, and we already received many references from EQuiP delegates, which is very nice. And finally, to produce and validate a set of European indicators for equity and use those indicators to assess equity in primary care in the European countries. And for example, look for social gradients of quality. We would like to thank the Paris meeting participants, among which there were EQuiP delegates, Isabelle and Marianne, the researchers, Yann Bourgueil, Sophia Chatelard, Madeleine Favre, Laurent Rigal et Virginie Ringat. We would like to thank also the experts who improved the questionnaire, André Rocheport and Gordon Littman for their precious help with English, and IRDES and its online survey software and IT support, Thomas Cartier, Jacques Arroin and Yann Bourgueil. Thank you for your